Hello and welcome to another segment of PA-SOS. My name is Maruf Hossein and today we'll be talking about pneumonia, or as we call it in our household, pneumonia. We'll start by talking about the different classifications of pneumonia as well as a brief understanding of the pathophysiology of how pneumonia actually occurs. We'll take an in-depth look into the different pathogens that are associated with pneumonias, one because this is something that is heavily tested on your boards, and two, because this is often something that troubles students the most when it comes to the topic of pneumonia. And then, of course, we'll take a look at the different clinical manifestations, as well as the diagnosis and management of pneumonias. In general, pneumonia is an infection of lung tissue due to a bacterial etiology, a viral etiology, or even at times a fungal etiology. In general, of course, most pneumonias will be bacterial in nature. Pneumonias are often classified based upon where a patient contracted the disease. For example, a community-acquired pneumonia is a pneumonia that was acquired anywhere outside of a healthcare setting. For example, it could have been even in the park or at a friend's house. Meanwhile, a nosocomial pneumonia is a pneumonia that's contracted while in a healthcare setting. Classically, this is a patient who has been hospitalized, and then about 2 to 3 days later, we notice that they're starting to have the signs and symptoms of a pneumonia. It can even be after intubation of a patient. It's important to identify nosocomial pneumonias because the pathogens that are associated with healthcare settings are often much more dangerous and require a much more aggressive course of antibiotics. You can also classify pneumonias as typical or atypical pneumonia. In general, typical pneumonias are pneumonias that have the very classic symptoms such as shortness of breath, high fevers, as well as very classic X-ray findings, which we'll discuss both in detail shortly. Typical pneumonias are classically caused by the pathogens that you see outlined here, and of course, we'll talk much more in depth about these pathogens very shortly. Atypical pneumonia, on the other hand, is any pneumonia that causes quote-unquote atypical symptoms. Usually you'll see that these symptoms are very vague and not the classic symptoms that we see with your typical pneumonias. We also often see that the X-ray findings for atypical pneumonia are very different from those of typical pneumonia. And again, we have the pathogens that we'll talk about shortly that are often associated with atypical pneumonias. In general, pneumonia begins with the entry of some sort of pathogen into the alveolus. For example, you breathe in some sort of microorganism and it makes its way through your airway into your alveoli. Now, your body basically tries to destroy these foreign pathogens by mounting things like neutrophils and macrophages, but in the process, it also causes some damage to the alveoli themselves. Now, if alveoli are your basic functional unit of the lung for things like gas exchange, you can imagine that all this inflammation will make it very difficult for things like oxygen to get into the alveoli, as well as for that oxygen to then diffuse through the alveolus and make its way into the surrounding capillaries. In essence, patients are going to feel very short of breath because of this difficulty with gas exchange. At times, patient may become tachypnic, meaning they breathe faster, in order to try and compensate for this decrease in oxygen. And ultimately, in very severe disease, patients may actually become hypoxic, where there's a total decrease in oxygen within the body. If that inflammation within the alveoli starts to expand to adjacent alveoli and even to the pleural sac, eventually patients may start complaining of pleuritic chest pain, which is pain with inspiration. These changes within the lung tissue can change what you hear when you auscultate a patient's lungs. Normally, when you have air enter into these distended alveoli, there's not a whole lot of noise that is made, and essentially you just hear what we call vesicular noises, or nice clear entry into the alveoli. However, let's say, for example, you have an infected alveolus instead. Well, because this alveolus is consolidated and very inflamed, it'll be a little bit harder for this alveolus to expand, such that when it does, you can actually hear crackling of the alveolus as it's trying to open up while you're taking a deep breath in. Of course, in very severe cases, if multitude of alveoli are infected, you start to get what we call a consolidation within the lung segment. And now all of these alveoli are unable to open up when you take a deep breath in, therefore causing a decrease in breath sounds in this segment whenever a patient inspires. Viral pneumonia act a little bit differently. While bacterial pneumonia classically infect the alveoli, in general, viral pneumonias will not really infect the alveoli, but instead will infect what we call the interstitium, or the surrounding area around the lung. Now, in general, for this reason, we don't really get a whole lot of shortness of breath or damage to these alveoli, which is good. But however, these viruses are very close to the capillaries that are within the interstitium, such that they can very quickly enter into these capillaries and diffuse all throughout the lung, causing a very widespread pneumonia. Now, keep in mind here that the alveoli themselves are relatively intact. And so when you listen to a patient's lungs, you won't hear as easily those crackles or even a decreased breath sound because the inflammation is more confined to the structural parts of the lung rather than to the alveoli themselves. I want to take some time to talk very thoroughly about the different pathogens that are involved with the different types of pneumonias. By far, the most common cause of pneumonia overall is Streptococcus pneumoniae. Streptococcus pneumoniae will classically be associated with community-acquired pneumonias. Again, remember that just means that it's a pneumonia that was contracted outside of a healthcare setting. And Streptococcus pneumoniae causes very classical pneumonia symptoms, and therefore it is called a typical pneumonia pathogen. One thing that might make you think that you're dealing with Streptococcus pneumoniae is a patient may experience what we call rusty colored sputum. That tends to be one of those buzzwords that you'll see for your board exams. The second most common cause of community-acquired pneumonias or pneumonias in general is Haemophilus influenza. Now, in general, Haemophilus influenza is a little bit more common in people with underlying pulmonary diseases like COPD or chronic obstructive pulmonary disease. While Streptococcus pneumoniae and Haemophilus influenzae are the most common causes of pneumonia for community-acquired pneumonias, remember that we said that we tend to see a little bit more dangerous pathogens when you have patients with nosocomial pneumonias, or pneumonias that were contracted within a healthcare setting. Staphylococcus aureus and Pseudomonas aeruginosa are two of those pathogens that we really worry about when we have a patient with nosocomial pneumonia. Staphylococcus aureus tends to be associated with IV drug abuse, but of course that's not the only reason that you may get a Staphylococcus aureus pneumonia. Sometimes one of the things that we worry about with Staphylococcus aureus is that it may cause lung abscesses and cavitations. There are a few other organisms that can also cause that, but try to remember that Staphylococcus aureus is one of those pathogens that is often associated with pneumonic abscesses or abscesses within the lungs. Pseudomonas aeruginosa is another nosocomial pathogen that can cause patients to be very sick. Now, while Pseudomonas aeruginosa is classically seen in patients who contract pneumonia within a healthcare setting, it may also be seen in patients with cystic fibrosis. We'll talk much more in detail about cystic fibrosis in a later segment, but in general, cystic fibrosis is a genetic disorder that causes a lot of disease within the lungs, making it much more likely for dangerous organisms like Pseudomonas aeruginosa to colonize their lung tissue. One of the things that's classic for Pseudomonas aeruginosa that can sometimes be a giveaway on a board question is that patients will have what we call a fruity or grapey odor. And at times, the sputum may appear to be this blue-green appearance. And I'll tell you, in real life, we don't often see this, but this is something that the boards like to use to make you think that we may be dealing with Pseudomonas. Some other pathogens that are associated with very typical pneumonia symptoms are Klebsiella pneumoniae and anaerobes. Klebsiella pneumoniae is a lot more commonly seen in patients who suffer from alcohol abuse, but can also be seen in patients with diabetes mellitus. Now, just like Staph aureus, Klebsiella pneumoniae is also often associated with lung abscesses and cavitations. So just another one that I need you to keep in mind that may be associated with abscesses. In addition to alcohol abuse, which sometimes is a giveaway for Klebsiella pneumoniae, we sometimes see that Klebsiella pneumoniae prefers to cause infection within the right upper lobe. Anaerobes are essentially associated with aspiration pneumonia, meaning that we had some sort of food particle or even just saliva get into the airways where they should not be. Now, of course, those pathogens that are found within your mouth should not get into your lungs, which is a sterile environment. Classically, patients with aspiration pneumonia suffer from some form of altered mental status. For example, this may be someone who all of a sudden became very sick and confused and accidentally aspirated. It can also be seen in patients who suffer from dysphagia. So keep in mind that people with stroke with dysphagia symptoms, for example, may sometimes suffer from aspiration pneumonia due to anaerobes. And so those are sometimes giveaways for an aspiration pneumonia. Classically, with aspiration pneumonia, we get a foul smelling sputum, or sometimes you'll see it called putrid sputum. And that is sometimes a giveaway for dealing with anaerobes. Also, anaerobic infections classically colonize the right lower lobe. And that's because if you think about it, if a food particle or saliva were to get anywhere in the lung, it would go to the place where gravity leads it the easiest. In general, we see that the right main stem bronchus is much more vertical and a little bit shorter as well, meaning that particles and saliva make its way easiest into the right lower lobe. Anaerobes as well are often associated with the lung abscesses and cavitations. So that's 3 different pathogens that we're now dealing with: Staph aureus, Klebsiella pneumoniae, as well as anaerobes that may cause lung abscesses and cavitations. We've talked a lot about the typical pneumonia pathogens. And remember, typical pneumonia pathogens are pathogens that cause your very classic typical pneumonia symptoms, which we'll talk about shortly. Atypical pneumonia pathogens are pathogens that cause very odd or different symptoms from your classic pneumonias. Mycoplasma pneumoniae is the most common cause of atypical pneumonia. Sometimes it's called a walking pneumonia. Classically, you'll see Mycoplasma pneumoniae in school-aged children or college students in their dorms, or even military recruits. And things like that are often a clear giveaway when you're reading a question stem that you're dealing with a Mycoplasma pneumoniae causing an atypical pneumonia. Legionella pneumonia, a rare cause of pneumonia, is also associated with atypical pneumonia symptoms. Now, classically, Legionella pneumonia will be associated with outbreaks due to some sort of contaminated water supply. So usually in the question stem, you'll see patients having contact with like air conditioners or cooling towers, and it's usually patients that are sick within a certain area because, again, it's associated with outbreaks. One of the things that make you think Legionella pneumonia is that this is one of the few pneumonias that are associated with gastrointestinal symptoms. So sometimes you'll see patients with what sound like pneumonia symptoms, but in addition with nausea, vomiting, or diarrhea. And that should make you think Legionella. Now remember that while bacteria are the most common causes of pneumonia, sometimes you can have pneumonia due to viruses or even fungi. For example, the influenza virus, while it's most commonly associated with upper respiratory infections, may also cause pneumonias or infections of the lungs. One thing that's important to know for your boards is that often an influenza pneumonia increases your risk of a subsequent Staph aureus pneumonia. So a question stem may say, for example, a patient is diagnosed with Staph aureus pneumonia. Maybe they have like cavitations or whatever have you. What possible pathogen may this patient have dealt with earlier? And the answer would be the influenza virus. Now, for those of you who care, the reason why is because influenza starts to attack the ciliary escalator within your lungs, essentially making it harder for you to clear pathogens out of your lungs and for you to cough it up, meaning that more virulent pathogens like Staph aureus can easily get in and cause a superimposed pneumonia. Pneumocystis jirovecii, previously called PCP, is a fungus that can often cause pneumonias in patients with immunocompromised states. Now, classically, you'll see Pneumocystis jirovecii in patients with HIV with low CD4 counts or with high viral load. But keep in mind that you may also see this in patients with organ transplant history, because people who undergo organ transplants are usually placed on medications that suppress their immune system. Now, we talked a whole lot about the pathogens, but what about the actual clinical manifestations themselves of the pneumonia? Well, your typical pneumonias, again, those are pneumonias that cause your classic symptoms of pneumonia, will be associated with things like fever, pleuritic chest pain, meaning that they feel chest pain with deep breaths in, as well as productive cough, shortness of breath, and even at times tachypnea. All these things, especially with the fevers and the coughing and chest pain, should make you think that you're dealing with some sort of infection of the lungs. Now, remember that when you take a listen to patients' lungs, you'll often hear crackles due to the fact that the alveoli are trying to expand against all of this inflammation that's inside them. Or at times, you may even hear decreased breath sounds because an entire segment of the lung with all these infected alveoli are dampening the amount of air that can get in. If you were to perform a chest x-ray, you'll often see what we call lobar consolidation, and we'll talk about shortly what that looks like. The boards love to talk about sputum, and sometimes these are the things that they use in order to make you understand what kind of pathogen you may be dealing with. So it is important to remember that things like Streptococcus pneumoniae are classically associated with a rusty colored sputum. Now, of course, I'm not going to find pictures of sputum for you because I don't want to kill your appetite. So instead, I just drew out the basic colors that you may see. Meanwhile, Pseudomonas is classically associated with that blue-green sputum. And so a patient that presents with a grapey or fruity odor to their sputum that looks blue-green should make you think Pseudomonas. Klebsiella is often associated with a currant jelly sputum, which is this bright red jelly-like color. And finally, anaerobes, although you're not actually coughing up poop, is going to smell very foul and putrid. And so those kinds of words should make you think that you're dealing with an anaerobic infection. Now, while typical pneumonias cause those classic symptoms of high-grade fever or a productive cough, atypical pneumonias will instead cause very low-grade fevers, usually a temperature less than 100.4, as well as classically a dry cough. In addition, atypical pneumonias will cause very vague upper respiratory or even viral-like symptoms like sore throat, body aches, what we call myalgias, or headaches. Realize that these kinds of symptoms aren't what we saw when we looked at typical pneumonias. Now, some things that might make you think that you're dealing with a particular pathogen are things like bullous meningitis, which is basically an otitis media with swelling and bubbling of the tympanic membrane. Now, I don't know if the boards will continue to use this because it's been outdated, but often they like to make you think that bullous meningitis is classically associated with Mycoplasma pneumoniae. We do see now in recent literature that's not actually the case, but just keep that in mind in case the boards continue to use that outdated information. As we said before, Legionella is classically associated with gastrointestinal symptoms like nausea, vomiting, and diarrhea. And at times you may even see things like elevated liver function tests, so elevated ALK phosphatase or alanine transferase. And you may even see hyponatremia associated with Legionella. So if you have a patient who is coming in with what sounds like vague pneumonia-like symptoms, like a dry cough, low-grade fever, but then they also have gastrointestinal symptoms, especially if they have been associated with an outbreak from water supplies, you should definitely think Legionella. Now remember that because the inflammation that occurs is primarily within the interstitium of the lungs, remember that's the supportive tissue of the lungs, usually don't have enough damage to the alveoli, and so air entry into your lungs is usually normal. Therefore, when you listen to patients' lungs, you'll often hear normal breath sounds. However, when you perform a chest x-ray, you may see what we call instead diffuse, patchy, or interstitial pattern. And that's why I wanted to show you what the interstitium looks like within a lung. So we'll see shortly that the chest x-ray pattern instead often looks like it's all over the place, but very thin-like. I wanted to talk very quickly about pneumocystis jirovecii, which is formerly known as PCP pneumonia. While PCP pneumonia will most commonly be found in patients with immunocompromised states like HIV or some sort of organ transplant with chronic immunosuppressant medications, the symptoms for PCP are usually the same as those for normal pneumonia. So patients will have fevers, productive coughs, shortness of breath, but the chest x-ray pattern, for some reason, instead causes interstitial patterns. And that tends to be one of the things that make you think right away that you're dealing with PCP, which is a patient with, for example, HIV or organ transplant history with a chest x-ray with diffuse, patchy, or interstitial patterns. It's very important that you identify this specific group of patients because the treatment will be very different. You must include Bactrim as part of your antibiotic regimen because Bactrim is the treatment for PCP. Now, we alluded a lot to chest x-ray findings, and that's because chest x-ray is the way that you will diagnose a patient with pneumonia. Now, in general, a chest x-ray diagnoses pneumonia, but doesn't diagnose the pathogen. However, certain chest x-ray patterns can suggest what kind of organism you may be dealing with. So for example, if you're dealing with a lobar consolidation, and again, that just means that you have a big chunk of lung segment that's filled with inflammation, those are classically going to be associated with your typical pneumonias. Keep in mind, the most common cause of typical pneumonia is strep pneumoniae. A right lower lobe consolidation can also be, of course, due to your typical pneumonias, but keep in mind that anaerobes can also infect the right lower lobe. So if you have a patient with risk factors for aspiration, like altered mental status, and they accidentally aspirated, and then you see an infection of the right lower lobe, definitely consider anaerobes as a possibility. The right upper lobe is usually not involved in typical pneumonias. Often you'll see right upper lobe consolidations associated with things like Klebsiella and even reactivation tuberculosis. We'll talk a lot more in detail about tuberculosis in later segments. The finding of a pulmonary abscess should make you think things like Staph aureus, anaerobes, or Klebsiella, because remember, those three organisms are often associated with abscesses within the lung tissue. And then lastly, a diffuse, patchy, or interstitial pattern is often associated with atypical pneumonias. Remember, by far the most common cause of atypical pneumonia is Mycoplasma pneumoniae. But even PCP can cause a diffuse, patchy, or interstitial pattern. And you should definitely think PCP if you have a patient with HIV or some sort of immunocompromising history. So let's see what these chest x-ray patterns actually look like. Here you'll see what we call a lobar consolidation. You can see that an entire segment of lung tissue is actually consolidated and inflamed. And this is classically seen with typical pneumonias. For example, due to Streptococcus pneumoniae, the most common cause of pneumonia overall. Keep in mind that if you had a right lower lobe consolidation, that could be again due to a typical pneumonia like Streptococcus pneumoniae, but you should definitely consider anaerobes if there are risk factors for aspiration. A right upper lobe consolidation, as you can see here, is often associated with Klebsiella or reactivation tuberculosis. And again, we'll talk more in detail about reactivation tuberculosis in later segments. If you see a pulmonary abscess, which classically has this ring with central blackness, which I've highlighted for you here, you should be thinking things like Staphylococcus aureus, anaerobes, or Klebsiella. And then, of course, if you have this diffuse, patchy, or interstitial pattern, you should be thinking things like atypical pneumonia or even PCP. Often students will look at this and they'll say, I have no idea what I'm looking at. But at the very least, you should start to realize that there's a lot of haziness on this chest x-ray. However, if I zoom in for you, you can see that the alveoli are actually still intact. You can see these black circles that look fairly uninvolved, and those are your pockets of alveoli. It's only the surrounding areas what we call the interstitium, that actually has the white or the inflammation, just like what we mentioned before with your interstitial pneumonia patterns. Now, while chest x-rays can help you kind of determine what organism you may be dealing with, the real way to determine what the organism is by doing a sputum gram stain or culture. This is something you'll see much more often done in inpatient services, but you probably will not see much of this when you're actually taking your boards. Keep in mind that there are certain other tests that you can perform to diagnose the specific kind of pathogen. For example, Legionella can actually be detected within the urine by looking for specific antigens associated with Legionella. While this test is relatively outdated, the cold agglutinin test used to be done in office to test for Mycoplasma pneumoniae. In general, Mycoplasma pneumoniae can sometimes cause cold agglutinin antibodies to increase in your body, and while that's not the only thing that can do that, this test, if positive, should make you think Mycoplasma pneumoniae. While you may not see procalcitonin on your boards, I do think it's important for you to know this one so you can impress your preceptors when you're out in your clinical phase. Procalcitonin is a new test that we've been performing in order to determine if we're dealing with a bacterial or a viral etiology for pneumonia. In general, we see that procalcitonin tends to be elevated with bacterial etiologies, while procalcitonin tends to be low or normal in viral pneumonias. You can imagine this is very important because you don't want to treat viral pneumonias with antibiotics, and thus procalcitonin can help us avoid unnecessary antibiotics. Now, it's important to realize that there are certain choices that you need to make when you've diagnosed a patient with pneumonia, and one of those is, am I going to admit this patient to the hospital, or am I going to let them go home? In general, we like to use what we call the CURB 65 rule in order to determine what a patient's risk factor is for poor outcomes. CURB 65 essentially stands for confusion, urea, like blood urea nitrogen greater than 20, respiratory rate greater than 30, essentially tachypnea, a blood pressure less than 90/60 or hypotension, and an age greater than 65 years old. As you accumulate more and more of these risk factors, your chances of having a bad outcome increases. In general, we see that patients who only score a 0 or a 1 or even a 2 out of these 5 items can generally do well with outpatient management. And that's going to determine what antibiotics you use, and we'll talk about that shortly. Meanwhile, patients with higher scores like 3, 4, or 5 generally benefit from inpatient management with much more aggressive and even IV antibiotics. Now, keep in mind that a score of 2 can kind of go either way, whether it's outpatient or inpatient management, and that's going to rely a lot on other factors like how sick does this patient really look. You probably won't see a score of 2 on your boards because they'll never make you choose between these two options. Now, let's say you've decided, you know what, this patient has a CURB 65 score of a 1 or maybe even a 2 or 0, and they can benefit from outpatient management of their antibiotics. Well, you can send them home, but with antibiotics like a macrolide. Classically, we use azithromycin, but my favorite is clarithromycin. If you don't want to use a macrolide, for example, if a patient is allergic, you can instead use doxycycline. Meanwhile, if you determine that this patient would be better managed inpatient because their CURB 65 score is greater than 2, then you can use the above management, either a macrolide or a doxycycline, but add on a beta-lactam antibiotic. Now, when you're thinking beta-lactam antibiotics, you're typically thinking things like penicillins or cephalosporins, and you usually see patients placed on something like ceftriaxone, which is a third-generation cephalosporin, along with azithromycin. Now, another option that you can use is just fluoroquinolones alone, like levofloxacin. We are trying to slowly move away from the use of fluoroquinolones due to all the negative side effects that are associated with them, but you may still see this as an option. Remember that nosocomial pneumonias, or pneumonias that were contracted while in the hospital, are often associated with Pseudomonas or Staph aureus, and thus your antibiotics need to be tailored towards killing these kinds of pathogens. In general, when you are dealing with a nosocomial pneumonia, you want to choose two Pseudomonas covering antibiotics. Now, typically, that'll be a Pseudomonas killing beta-lactam like cefepime, a fourth generation cephalosporin, or piperacillin tazobactam, which is a high grade penicillin, in addition to something like a fluoroquinolone or an aminoglycoside. Aminoglycosides could be like gentamicin, while fluoroquinolone can again be like levofloxacin. So again, you need to have a beta-lactam as well as another medication, whether it's a fluoroquinolone or an aminoglycoside. Keep in mind that if you suspect MRSA, for example, you see abscesses in the lungs, or this patient has a history of IV drug abuse, you should consider adding on vancomycin, which can target Staph aureus, and particularly methicillin-resistant Staph aureus, a much more dangerous form of Staph aureus. So let's test your understanding of pneumonia. Let's say, for example, you have a 62-year-old male with a history of COPD who's presenting to your clinic with chest pain, a productive cough associated with yellow sputum, and a fever of 101.8 for the past 5 days. The patient describes the chest pain as diffuse and worse with inspiration, but otherwise the patient denies any leg swelling, recent travel, radiation of chest pain, or recent hospitalization. On physical examination, the patient is ill-appearing, warm to the touch, and in mild respiratory distress. Auscultation reveals crackles auscultated at the left lower lung field. Now, this question might seem quite difficult because there are a lot of information in here. However, you can kind of narrow down what you may be dealing with just by looking at some of the key features here. One of them is the fact that you have a patient who is 62 years old, but also has a history of COPD, a lung disease that can increase the risk of certain pathogens. You also see that this patient has a cough productive of yellow sputum. So a productive cough should make you think typical pneumonias, as well as a fever, like a high-grade fever. Again, that should make you think typical pneumonias. And remember, the most common cause of typical pneumonia is strep pneumoniae. This patient has chest pain that's worse with inspiration, which is, again, just describing pleuritic chest pain, a common symptom of pneumonia. And then you do see that this patient denies recent hospitalization, and that's to make you certain that we're not dealing with a nosocomial pneumonia. The patient has some mild respiratory distress, and when you listen, you hear those crackles. And again, crackles can be associated with an infection of the lungs due to a bacterial pathology. So let's take a look at the first part here. What is the most likely pathogen that you're dealing with? Well, remember, in general, the most common cause of typical pneumonia is Streptococcus pneumoniae. And the type of consolidation that you're most likely going to see with this is a lobar consolidation, meaning that an entire segment of lung is consolidated with inflammation and bacterial infection. And in order to treat community-acquired pneumonia due to strep pneumoniae, the first-line medication should either be a macrolide, like azithromycin or clarithromycin, or if the patient is allergic, you can use doxycycline. Now, we see that this patient has a history of COPD, and remember that patients with a history of lung disease, like chronic obstructive pulmonary disease, will be at increased risk of Haemophilus influenzae, which is the second most common cause of pneumonia. Now, in general, even with a history of COPD, the patient's most likely pathogen is strep pneumo, but you have to keep in mind that Haemophilus influenzae may also be a pathogen that you're dealing with here because this patient has a risk factor. Now, imagine this patient had suffered from a recent flu-like illness. Well, that should start making you think right away Staphylococcus aureus. Remember that Staphylococcus aureus can sometimes superinfect or superimpose upon an influenzae pneumonia. Now, what if this patient had a history of chronic alcohol abuse? Well, as soon as you hear pneumonia and alcohol abuse, you should think right away Klebsiella. And remember that Klebsiella classically causes a current jelly sputum and sometimes will infect much more commonly in the right upper lobe and can even cause abscesses. Now, let's say instead this patient had altered mental status or some sort of history of aspiration. Well, right away, you should be thinking about aspiration pneumonia due to anaerobes. And usually, aspiration pneumonia will land in the right lower lobe. And it's classically associated with that putrid or foul smelling sputum. Now, what if instead this patient was in the military or had a history of military employment? Well, that should start making you think something like mycoplasma pneumonia. Remember, mycoplasma pneumonia, which is the most common cause of atypical pneumonia, is usually seen in patients with school-aged or military background. Now, of course, patients with mycoplasma pneumonia wouldn't have the kind of symptoms we talked about at this first patient and would instead have very vague-like symptoms like body aches, a dry cough, sore throat, or low-grade fevers. And the chest x-ray would classically look like it has some interstitial diffuse pattern, or may even look normal. And while we don't do this anymore, a cold agglutinin test that is positive would suggest that we're dealing with mycoplasma pneumonia. Now, if we had a patient who had a history of HIV, remember right away we need to start considering that this patient may have PCP pneumonia or pneumocystis jirovecii pneumonia. And the treatment should always include Bactrim. Now, remember that the chest x-ray findings for PCP pneumonia is usually interstitial pattern. What if instead you had a patient who you suspected had Legionella as the source of their pneumonia? Well, not only would that patient have most likely gastrointestinal symptoms, hyponatremia, LFT elevations, but you would also see this patient have a history of some sort of exposure to a contaminated water supply. What if instead you have a patient that was recently hospitalized? Well, then you have to start thinking about two pathogens that are classically associated with nosocomial pneumonia, which are Staphylococcus aureus and Pseudomonas. Remember that when we're treating nosocomial pneumonia, we have to choose two antibiotics that cover Pseudomonas. One of them is usually a beta-lactam, and the other one is either levaquin or some sort of fluoroquinolone, or an aminoglycoside like gentamicin. Hopefully this was helpful in increasing your understanding of pneumonia, particularly the different pathogens that are associated with pneumonia, as well as how you go about treating the different forms of pneumonia. If you have any questions, feel free to leave them at the bottom, and as always, best of luck.